Diallo, President-elect and Chairman, Education Committee of the Nigerian Society of Anaesthetists. And I'm very pleased on behalf of the President of the Nigerian Society of Anaesthetists and the entire Education Committee to welcome you all to our bi-monthly webinar. As you all know, since the beginning of the year, we've had every 2 months, we come up with one general webinar or the other. Throughout the year, every 2 weeks, our residents have their own webinar where many of us have joined and they have been very educative. I want to remind us all that all the webinars are loaded on our YouTube channel. And in the past few months of this year, we have collaborated with different committees of the NSA. We collaborated with our colleagues in the aviation industry, knowing the similarity of anesthesia safety with safety in aviation. And a few months back, we also did a collaboration with the basic life support in communities. All these again are loaded in our YouTube channel and you can go back at your leisure to listen to them. And today we are going to look a little bit at ourselves as caregivers. So we are collaborating with the Wellness Committee of the Nigerian Society of Anaesthetists, ably led by Dr. Mary Rose Osazwa, who is on this call. Madam, thank you very much for the hard work behind the scenes. And members of her committee are also on the call. So we are going to have a lead speaker, and then we are going to have panelists drawn from many of our revered colleagues, from the very senior to immediate seniors. And we have a lot to learn from all of our colleagues who are on the panel. So on behalf of the Education Committee, I want to welcome you to what promises to be a very interesting academic feast. You're all welcome. So on that note, I want to let us know some of the ground rules. Everyone is expected to mute their devices. And please, it is only when you're signaled to speak that you should kindly unmute so that we can hear you. And you should please all turn off your videos so that it doesn't also interfere with the call unless when you're signaled to speak. We would advise that we all rename our devices so that we know those who are on the call. We usually take attendances and we try to see those who have kept faith with these educational programs. And then lastly, we would like you to put your questions and comments in the chat, and they will be read at the appropriate time when we are taking questions and answers. Once again, you are welcome. Moderator, please.
Good afternoon, ladies and gentlemen. My name is Dr. Ifa Torangsi, and today I'll be moderating the webinar with Dr. Rotimi Muyiwa. And today, like we all know, we have our webinar, and the topic for the webinar is mentoring and mentorship in anesthesia training and practice. And we have none other than Dr. Rosemary Mabon Nwokorie as the resource person for today. She will be taking us, educating us and enlightening us on the topic for today. Dr. Nwokorie is a fellow of the West African College of Surgeons, and she is a chief consultant anesthetist at the Asokoro District Hospital, Abuja. Dr. Nwokorie is also a lecturer at the NAL University, Abuja, and where she's the head of department, and also She is also the head of clinical services at the Asokoro District Hospital, and she is the coordinator of the residency training program in anesthesia in the FCTA hospitals. She has interest in regional anesthesia and critical care, and she is an examiner in anesthesia in the Faculty of Anesthesia, West African College of Surgeons. At this juncture, permit me to offer the floor to Dr. Nwokorie for her presentation today. Thank you very much. Dr. Nwokorie, you have the floor, please.
Thank you, Dr. Oransi. Good afternoon, everyone. It's such a huge privilege to be able to speak to this distinguished audience, my respected elders, senior colleagues, and colleagues on mentoring and mentorship in anesthesia training and practice. As already been said, my name is Dr. Nwokere from Asokoro Hospital. I have to reshare again, so. All right, so at the end of this session, hopefully we'll be able to understand the concepts of mentoring, coaching and teaching, the qualities of a good mentor-mentee, models of mentoring, the nitty-gritty of mentorship in anesthesia, training and practice, ethical issues, and the challenges. I'll be using the following outline. By way of introduction, mentorship plays an important role in medical education, both at the undergraduate and postgraduate level, and also in the development of the medical profession. And it involves a collaborative learning relationship, which is bi-directional. We could go either way, providing knowledge, guidance, and support, which is crucial for encouraging the growth of future anesthetists by creating a supportive and enabling environment. The purpose generally is to foster trust, guidance, and mutual growth for both parties. Well, by way of statistics, the global density of physician anesthetists as at 2024 was 7.6 in 100,000 population. As at 2020 in Nigeria, as reported by our respected elder, Dr. Bishola Obembe, it was 0.51 in 100,000 population. And that was before the mass exodus of anesthetists outside the country. So I can imagine what it is now. Now, if we compare that to the WHO recommendation of at least 4 to 5 per 100,000, we know that there's really a problem. This is just a graphic representation of what I spoke about. Time won't permit me to go into details of what obtains in other parts of the world. Mentorship, the history goes back to Greek mythology, when Odysseus handed over his teenage son to be mentored by a friend when he went to war. In anesthesia, it has evolved from informal guidance to structured programs that emerged in late 20th and 21st centuries. And with complex healthcare systems evolving, formal mentorship programs as obtainable in the World Federation of Societies of Anesthesia and Pediatric Anesthesia Training in Africa have gained recognition. Definitions. Mentorship can be defined as a two-way relationship within an academic or professional context where knowledge, skills, and experience is shared to support and advance the career of the mentee. Mentoring is the act of providing mentorship. A mentor is an experienced and trusted advisor who trains, counsels, and supports a less experienced person to develop not just professionally, but also personally, while the mentee is the individual who receives this support and knowledge from a more experienced person. Now, if we're going to examine mentorship vis-a-vis coaching and teaching, where definitely there are overlaps, but mentoring is more about relationship and long-term. And it involves adaptive methods and experiential methods to bring up somebody who is less experienced in a field to be able to stand on his or her own and be able to also mentor others. In contrast, coaching is short-term and performance-driven. In other words, a coach looks at a person with the innate ability and tries to maximize the potentials by giving directive based on structure. While teaching usually is one way, a teacher is the expert teaching a less experienced person to gain knowledge, and this knowledge is usually curriculum-based. There are several components of mentoring, but we're just going to pick a few because of time. To have good mentorship, they should be trained and willing mentors. Nobody should be forced to mentor, and the mentee should be committed to being mentored. There should be clear goals and excellent communication skills with respect of boundaries mutually, and of course, feedback and evaluation. Several models of mentoring exist. By relationship structure, it could be one-on-one, group or team, and mentoring. These are all self-explanatory, so I'm not going to dwell on them. And then if we're classifying it based on focus or content, you could have career mentoring, which is what is mostly obtainable in anesthesia. But somehow, because remember, we said mentorship is bi-directional, you could have reverse mentoring. And that means someone that's senior in a particular could be mentored by a younger person in quotes in a particular area where he or she requires more knowledge. And then you have cross-functional mentoring, which is interprofessional. For instance, if you're an academician, You could be mentored by data scientists, you could be mentored by a statistician to help you gain more knowledge in that area and on. Then by format, you have formal and informal mentoring. The formal mentoring is more structured and institutionalized, usually involves mentors being assigned to mentees and vice versa. And it's a very formal relationship with clear goals and a start and end date. Meanwhile, informal mentoring, which is commoner, involves a spontaneous evolving relationship, which is characterized by deeper connections and lasts much longer. No thanks to COVID-19, virtual or e-monitoring is now very common. We have people being mentored by people there, probably by proxy, probably by people they've not yet seen, through their books, through videos, blogs. For instance, we have Prof. Toby has his YouTube channel that he posts educational materials. I'm sure through that, a lot of people are being mentored. Now, the different stages of the mentoring relationship, there are 4. The first stage is the initiation stage, where you get to meet your mentor, you understand the motivations. Why do you want to be mentored? Or why are you mentoring? Expectations are clarified and roles defined. The cultivation stage is where ground rules are set and boundaries are established. Meeting schedules are also clearly defined. And then there's a criteria. When can I say that I've been successfully mentored? And then the engagement stage, which is the most intensive, where there's continuous learning, deeper engagements, and focused guidance with feedback. That means you're into the process and there's close monitoring, there's greater interaction. And then, of course, the separation stage, where there are less frequent meetings. I like to think of mentorship like a weaning process. When you have, like a mother bringing up the children, you have brought up this baby and it's growing. And with time, the baby gains independence. Although this is said to mark the end of mentorship, we all know that with time, especially the informal mentoring, evolves into a lifelong relationship that transcends through the career of the mentee. The qualities of a good mentor. Well, I'm thinking of which one to choose because of time, but a mentor should be willing to share. The worst case scenario is that you should produce someone just as good as you are. And the best case scenario is to produce an anesthetist that is a better version of you. You should have a positive attitude in mentoring, always believing the best from your mentee, and you should be a good role model with excellent communication skills. I want to quickly say here that this aspect is very important when mentoring, because you have to learn non-verbal cues. When you're listening to your residents or you're watching, you have to learn their body language. That's when you get to know what they are passing through, at what level they are. And you should be able to provide active guidance and constructive feedback, all the while allowing for individuality. The way you mentor Dr. A may be different from the way you mentor Dr. B. The role of a mentor wears many caps. You're advising, sharing your knowledge and experience. You're acting as a role model, whether you like it or not, both in training and character. You're supportive, you're a counselor, you're giving instructions as a tutor, you're celebrating milestones and building self-esteem and giving this individual a unique identity. A mentee should be proactive in seeking guidance. It's not a passive role, and you should seek a mentor best suited for your growth. And that's where the informal mentorship has a superior hand. There should be open and honest communication. You shouldn't try to over-impress your mentor. You should let your mentor know exactly where you are and where you need help. And you should be willing and receptive. You should be willing to learn and receptive to criticisms with commitment to succeed. Now, benefits for the mentor. Of course, by the time you're mentoring, you're learning. You have career enhancements with heightened sense of responsibility. Just feel responsible for someone or a group of individuals. And this sharpens your leadership skills. You have better communication skills. You can pick up when a resident comes to work and is faltering at things he normally does. And then what's going on? Is everything okay? And all of that. And then, of course, a broader network of influence. But I want to think that the greatest is in fulfillment of building the next generation of professionals. Just recently, we are mourning. We've lost 2 of our very senior, great anesthetists who have mentors of mentors, and their legacy will not die. We remember Baba for the School of Anaesthesia in Badagry. Every time somebody passes through the institution, he will be blessed and prayed for, and his family will be remembered. And I think this is what I'm noting. Beyond the professional recognition and all of that, you have played a role in building up the next generation of professionals so that anesthesia will not recede. Now for the mentee, of course, career advancements. skills development, improved performance, ultimately resulting in enhanced patient care. And of course, you tap into the network of your mentor and have an expanded network with accountability to someone. Now, heading quickly to the nitty-gritty of mentorship in anesthesia, this usually involves a senior and junior anesthetist, though it could be bidirectional, like we said. And why is it important in anesthesia? Anesthesia is such a high, stressful nature of specialty. You work long, unpredictable hours with a potential burnout syndrome. And then you're dealing with complex cases and difficult work environment, dealing with difficult surgeons who are on your neck and all that. So you need someone to hold your hand to navigate this pathway. In terms of academic development in research, you need someone to mentor you and guide you through academic writings. And when you have issues, you know who to go to. For those preparing for their part 2, what are the WACS guidelines? How do you adhere to it? How do you prepare for your dissertation? And then at every other level, the curriculum for exams, how do you answer your exams? How do you answer both oral questions, theoretical questions? In all of this, you need someone to help you in planning your time schedule and to put in your best and be successful. In terms of clinical practice, which bridges the gap between theory and practice, we have entrustable professional activities, which I'll be looking at shortly. And then, of course, work-life balance. Anesthesia has, in different places, a peculiar anesthesia landscape. So you must learn how to, while not being careless at work, you should be able to balance your lifestyle so that no aspect of your life suffers and you become a well-rounded anesthetist. And of course, this is unique for different levels of training and individuals. Now, for the junior residents, there's need for patience because they're just coming into the specialty, they're naive, and you're limited in knowledge and skills, and usually overwhelmed. I remember when we started residency in our place, after like a month or 2 months, so the residents like, well, we had no idea that anesthesia is like this. I said, you're welcome to anesthesia, but you can do it. And look at them now. Some of them are senior registrars, some of them are preparing for their part 1. And so one has to be careful in mentoring these young ones to encourage them, constructive criticism. Sometimes they do things that are so crazy, but you don't need to tear them down, guide them along the right path and help them to navigate to the relationship with other anesthesia providers and theater workers. For instance, you are working in a place where you have nurse anesthetists, and you know there's always this kind of tension. You should be able to help them while being respectful, to be firm when they know that they're doing something wrong, and of course, to have you as their support. When mentoring the senior residents, there's usually the choice of subspecialty. What area are you interested in? Why are you interested in this area? And then on and on. Preparing them for leadership and decision makings. They watch you as you're taking decisions. This case, are we going to take it? Now it's an emergency, but this is not there. It's not optimized. Are we rescheduling? Are we canceling the case? Or we are all set to run a list and then the machine in this theater is broken down. We're canceling the list. Can we bring a machine from another theater where there is no list? You know, all those kind of things. Then interpersonal communication. How do you relate to patients? How do you relate to the patient's relations? When things are going wrong, when surgery is prolonged, is longer than necessary and all of that. Then resolution of conflicts, of course, in theater and all of that. Principles, audits. When things don't go the way we expect them to go, do you sit down and take stock, or do you just gloss over it and go to the next patient? And of course, these people tap into the network of their mentors. Now, going back in detail to the entrustable professional activities, these are specific, identifiable tasks that a trainee can be trusted to carry out independently after achieving adequate competence. And usually what this does is it integrates the knowledge, skills, and attitude into work activities that can easily be assessed. And this provides a practical framework for competence-based medical education. And what do I mean? Defining tasks with timelines. For instance, if it's decided that before you go for your part 1, you should be able to put in a central line, or when you start your residency program, within the first 3 months, you'll be able to do a subarachnoid blocks, then this should be clearly defined with timelines and with graduated trust. That means, just as I said in the earlier on, just as a mother, when you watch your child is growing with confidence, you tend to step back and let this child be able to operate even more confidently and know when to ask for help. And then assessment tools. Is it the formative or the summative assessment? We all know that formative is assessment on the go. That means you're not waiting until the end of training to assess which is what is obtainable now, but rather you're assessing these residents as they work in theater, as they present during seminars, as they discuss during ward teachings and all of that, and you're forming an opinion, which I think is a more rounded and balanced way of assessment, because just at the end of training, anything could go wrong, and an extremely skilled and bright resident can just find him or herself, because of the peculiar circumstances of the exam period, failing. And then there should be curriculum design, workplace-based learning, and of course, allowance for individual pace. That Dr. A was able to do an epidural within 1 year doesn't mean it should be the standard. While it should be encouraged, people should be allowed to grow at their individual pace. What are the benefits? Clarity of expectations. So if this is set in the curriculum, it's known everywhere that by the time someone is coming to part 1, this doctor, this mentee has already acquired these skills, and we are confident that wherever he goes, we can entrust this mentee to perform. And then, of course, the structure, global standard and adoption, improved training, because whatever we do, the aim is to enhance patient safety. So where are we now? In 2024, WFSA Global Mentoring Program was implemented. Now we have parts, I think right now at National Hospital, people are being trained in pediatric anesthesia. NSA, we are mentoring through webinars, which is what's happening now, both the general one and one for the residents, the online platforms, the workshops and collaborations. And then at the hospital levels, we have seminars, we have ward teachings, mortality reviews, and all of that. So in all these programs, we are mentoring and ensuring that the next generation of anesthetists are preserved. Now, this is the geographical distribution of WFSA mentors and mentees. You can see the highest is mentees come from Africa. Time will not permit us to look into details. And then obstetrics, pediatric, regional intensive care have the highest number of mentors. Way to go. I think mentorship shouldn't be left to just drift along like a ship just drifting on the sea. There should be intentionality. We should have a plan. And that means when you decide to be a mentor, there should be a plan in place to mentor correctly. The faculty should integrate EPAs in the curriculum with clearly defined timelines and important skills needed for practice. It could be use of video laryngoscope, it could be an epidural, it could be passing invasive lines, both central and arterial, and all of that. And this should be stated for the different levels of training and the levels of supervision needed for them. And of course, assessment methods like we talked about, both formative and summative, and then not neglecting the regular training of the mentors. Ethical issues. In mentorship, there should be psychological safety. What do I mean? Mentees should be allowed to make mistakes, should be allowed to express their opinion, no matter how silly. Normally, there's a tendency to like, where did that come from? Did you just say that? You know, but they should be made to feel safe, that the mentorship relationship should be a safe place where they can open up where they have difficulties. They shouldn't want to unconsciously over-impress their mentors such that the mentors do not even know where they're lacking in knowledge and skills. And of course, there should be professionalism. That means there shouldn't be manipulation. People shouldn't be made to feel, if I don't do this for my mentor, then I stand a chance of being ignored or not being mentored properly. And it's gender-based. In some places, working closely with the opposite sex could be a problem. So all these factors should be put into consideration to ensure that we have a good mentorship. Potential challenges, overdependence. We must learn when to let the resident go and stand on his or her own. A lot of people, no matter how often they do a procedure, they want you by their side. But gradually, you should know when to separate and allow them to gain more confidence. Communication issues, personality clashes, this happens a lot, but somehow this is avoided in informal mentoring because you choose your mentor or your mentor chooses you, whichever way. And so there is a natural, spontaneous relationship that is evolved. Mistrust is, you can't overemphasize this. You must trust your mentor to guide you along the right path. You must trust your mentor when he or she says, I don't think you're ready for this. I think you should step back a bit, or I think you should put more effort without feeling that you're being looked down on. Of course, paucity of skilled mentors and time constraints, because even your mentor is being mentored by someone or is busy with his or her own life. So that is a problem. Blurred boundaries, misaligned expectations, and then in global programs, you have language barriers. For instance, if you're assigned to a mentor that speaks just French and you're English, there's going to be a problem. In conclusion, effective mentorship is crucial for better trained professionals. It contributes to their well-being and ensures better patient care, creating a successful future for the mentee. To maximize the gains, it should be structured. It is a mutually beneficial relationship with numerous benefits. These are my references. Thank you so much for listening.
Thank you very much, Dr. Okore, for this wonderful, concise, and very educating lecture. Just a brief recap. You did inform us that mentorship is a two-way relationship between a mentor and a mentee. And of course, you told us it's a long-term relationship that aims to bring up a mentee to be able to stand on his own and to be a future mentor for others. You told us that you informed us of the differences between mentoring, teaching, and coaching. And you said that mentorship should have set clear goals, and there should be excellent communication skills and mutual respect between the mentor and the mentee. You also informed us that there are various models of mentoring, and also of the different stages of a mentoring relationship, including the initiation stage, cultivation, engagement, and the separation stage. You also informed us that a mentor should aim to produce anesthetists that are better versions of himself. And you informed us of the mentorship program set up by the WFSA, the Global Mentoring Program, which was commenced in 2024, and also informed us of the Pediatric Anesthesia Training Program that is ongoing at the National Hospital, Abuja. They've also mentioned the work and the effort done by the Nigerian Society of Anaesthetists in training and mentorship. And you also informed us of the need for intentionality in training and mentorship, that there should be levels of supervision, because it's important to monitor, assess, and supervise the mentees. And you also told us about the benefits of mentorship to mentees. You also highlighted the ethical issues that are of importance in a mentor-mentee relationship. Told us about the need for psychological safety for mentees, the importance of professionalism and power balance in the mentor-mentee relationship, and also the importance of gender-based and cultural differences. And you also mentioned the potential challenges in mentorship, which you said include a lack of commitment, problems with communication, mistrust, and of course, language barriers. Thank you very much, Ma, for your lecture. And at this point, I want to invite my fellow moderator, Dr. Rotimi Muyiwa, to take the floor for the second phase of this webinar. Thank you very much. Dr. Rotimi, you have the floor, please.
Yeah, thank you very much, Dr. Anusi. I want to sincerely appreciate Dr. Okore to you for the excellent and very insightful presentation. It was an overview, and that has given us a good soft landing for this webinar. This webinar is a little deviation from the regular webinars we have, where we talk about principles and practice of anesthesia, clinical measurement, instrumentation, pain management, critical care. Is very germane and very unique, talking about mentorship and mentee relationship. So it's very, very important. And this evening we have 5 giants in anesthesia, and we really appreciate them for taking time out of their busy schedules to be at this meeting, because this meeting is very, very important. Isaac Newton, a renowned scientist, said something That's very, very important. He said that if I've seen further, it is by standing on the shoulders of giants. So most of us, we've seen further because we have been able to stand on shoulders of giants. And if we want to go fast, you go alone. But if you want to go far, then you have to go together. So this aspect of mentorship is very, very important, and I want us to pay attention to it. So we are going to recognize these are very, very senior colleagues. They are trainers of trainers, mentors of mentees, that mentees have now become mentors. They are scholars, they are teachers, they are professors, researchers, name it. And we are really blessed in anesthesia. So I'm going to start with the first panelist. We'll introduce them thereafter. Then we'll now start the discussion. So the first person is Professor Eniola Elegbe. She's a mother, grandmother, great-grandmother. She's a fellow of Faculty of Anaesthesia, Royal College of Surgeons, Ireland, and also fellow of both West African College of Surgeons and National Medical College too. For the past 5 decades, she has been involved in active teaching of postgraduate trainees in diploma and fellowship. At one time, she was secretary of Postgraduate Medical College, chairman of West African College, chief examiner, and currently she's hospital consultant, LAUTECH, and Uni Osun Teaching Hospital, Osogbo. You are welcome, Prof. Ma.
Thank you.
Thank you.
I hope you can hear my voice.
Yes, loud and clear. Thank you very much, ma, for honoring our invitation.
Okay.
Dr. Anusi, please.
Thank you very much, Dr. Rotimi. I'd like to introduce to us our second panelist, none other than Professor Olaitan Soyonwo. Professor Soyonwo is a fellow of the West African College of Surgeons, and she's also a fellow of the International College of Surgeons and the Nigerian Academy of Science. She has been the past head of Department of Anesthesia, College of Medicine, University of Ibadan. She's also served as the Dean of Clinical Sciences, College of Medicine, University of Ibadan. Prof has served as the visiting professor of anesthesia at the Olabisi Onabanjo University, Ago-Iwoye, and she is a member of the National Cancer Consultative Committee and is a pioneer member of the Board of Trustees of the Hospice and Palliative Care Association of Nigeria. Professor Soyonwo is a trainer of trainers. She's an examiner at the West African College of Surgeons. She has been an examiner since 1984, and she has served as an external examiner for the Diploma in Anesthesia Exams program at the Faculty of Science and Health in the University of Abomey Calavi, Cotonou, Benin Republic. She has published over 100 scientific articles, and she is the president of the Center for Palliative Care Nigeria. Prof is referred to in Anesthesia Nigeria as the grandmother of pain and palliative care Nigeria. Dr. Rotimi, onward to you, please.
You're welcome, Prof. Ma.
Thank you very much.
Yeah, good to hear your voice, ma. Thank you very much. The next person I would like to introduce is Professor Stella Eguma. She is a fellow of West African College of Surgeons the past 3 decades now. In 2000, she was invited to Aminu Kano Teaching Hospital, and also in 2006, Usman Dafodo Teaching Hospital, Sokoto, to establish their anesthesia residency training program. She left a mark in training, in coaching, and mentoring of new breed of residents who are now consultants, and they are holding forth in northern part of the country. She has served at various times as secretary, the chairman, West African College of Surgeons, chief examiner, internal assessor, and also committee member. So at the moment, she's a member board of trustees of West African College of Surgeons. She's retired but not tired. Prof. Ma, you're welcome.
Thank you very much.
Thank you, Ma. Dr. Anaesthesia, please.
Yes, please. The next panelist is Professor Bolaji. He is a fellow of the National Postgraduate Medical College of Nigeria and the West African College of Surgeons. He is the former faculty chairman of Faculty of Anesthesia of the National Postgraduate Medical College and also former faculty secretary of the National Postgraduate Medical College. Professor Bolaji is an examiner in the Faculty of Anesthesia of the National Postgraduate Medical College. He has served as the head of Department of Anesthesia in the University of Ilorin, and he is the chairman of the Tertiary Institutions Social Health Program of the University of Ilorin Teaching Hospital. Prof, you're welcome to the program, sir.
Thank you very much for inviting me. Thank you.
Thank you, sir. So the last but not least, have the honor of introducing who I refer to as my mom in academics. So please, Professor Ibironke Desalu. She's a professor of anesthesia at College of Medicine, University of Lagos, and an honorary consultant pediatric anesthetist at Lagos University Teaching Hospital. She is a fellow of both West African College of Surgeons and also National Postgraduate Medical College. And she holds postgraduate qualification MD in anesthesia, as well as fellow of the Faculty of Emergency Medicine, and recently fellow of Nigerian Academy of Medicine. Her career spans over 3 decades, and she's a pioneer trainer in pediatric and neonatal anesthesia, cardiopulmonary resuscitation, and patient blood management in Nigeria. She has coordinated numerous training courses in anesthesia, including Safe PEDS, Safe CLEP, Safe Anesthesia, Deliver Smiles, and cardiopulmonary resuscitation. She is an examiner at both West African College of Surgeons and National Postgraduate College of Nigeria. And she is passionate about under and postgraduate training and has supervised more than 25 fellowship dissertations. Prof. Ma, we are very happy to have you. You're welcome, Ma.
Thank you very much, Dr. Rotimi.
Thank you, Ma. So without much ado, we go straight to the panel discussion, and we give each of them 5 minutes each to just share their experience about what mentorship is all about, and also if, whatever they need to let us know. So if you have questions, please, questions will be taken after this first round of 5 minutes. And so you can use the chat box, and if you want to raise your electronic hand, you'll be recognized after this session. So I will start with Professor Elegbema. So what is your definition of effective mentorship? What can you say about mentorship, Ma?
Good evening, everyone. Thank you. Good evening.
Yeah, good evening.
I'll start by congratulating Mary Rose for an excellent presentation. I think this evening I'd like to share my experience, personal and kind of global. I think, like she said, mentorship can be on a one-to-one level. And the aim is for the mentee to be better than the mentor, to imitate, to acquire some of the good qualities of the mentor. It could also be a group thing. And I can say in my experience as lecturer and trainer at UCH, we used to have a departmental meeting every month for the consultant. And we socialize and we learn, because I think we have about 2 or 3 junior consultants. And we learn a lot of administrative things, because the running of the department is exposed and discussed. So we learn a lot from that. So that's like a kind of group mentoring. And mentoring could also be on request, or it could also be by intuition, or it will come along due to certain circumstances. And I'll give a few examples. Now, on a personal level, I finished my diploma successfully in 1973. And Professor Dunto, my mentor, called me on the corridor and said, Eniola, I'd like to see you in my office. I got there and he said, you are a fellowship candidate, and I have arranged for you to be to have your training in Cambridge, United Kingdom. My goodness, sir, I have babies. That was my response. I said, well, you'll have to take care of that. The program starts September 1973. My second question to him was, sir, what about my husband? Of course, he knows him. And he said, well, I'll arrange for a kind of fellowship for him in England as time goes on. So with that, I was empowered and encouraged. And I made every preparation for my mother to take care of my children. And then I took off. Of course, I didn't make any arrangement for anybody to take care of my husband. So I took off. And I met another mentor when I got to England. She had worked in Nigeria. As a matter of fact, she has worked at Luth as a consultant anesthetist, and he was brought in to help with the department. And she went back to Cambridge, and I was asked to go to her. She was a fantastic mentor. And when I make mistakes, she holds me up. When I need to be emboldened, she does. I'll give you a few examples. First one, I was doing neurosurgery with her. She was always doing the neurosurgical list. And one morning, she failed to turn up in the theater. And I phoned her frantically. I said, Ma, we're waiting for you. She said, no, wait for me. Start the case. And this was a posterior fossa in sitting position. And of course, by the grace of God and my experience and my knowledge, I was able to start the case successfully. The surgeon started. I was very nervous, waiting for her. She never turned up for that day. And that was the only case we did. So that's a way of emboldening me. And I'm sure she was monitoring me one way or the other. And the second one I also want to say is, well, that's on a private. The second one, my experience with scolding somebody. When a mentor makes a mistake, you call the mentor nicely and you scold. I had I think it was a 4-year-old baby that they were going to do a tracheostomy on. And they called me. I was the registrar on call. And they said they have this baby that they want to do a tracheostomy. I said, no problem. Is the theater ready? I went to see the patient. I was quite happy to anesthetize the patient. And I went into theater, dressed up. I noticed that when the patient came in, the surgeon was a bit agitated, as well as the matron that scrubbed for the case. I didn't know why they were agitated, but I felt a bit, I dismissed it because I felt, well, maybe because I'm Black. because you have that problem of your skin there. So I carried on. And the moment I put the endotracheal tube in, the sister just dropped what she was holding and said, "You saved her life." I didn't know why she did that. And then the surgeon, after the surgery, came to me and bowed and said, "Thank you." A senior surgeon. In the morning, my mentor called me to her office and said, come here. Now, you are in England. You are not in Nigeria. You have done a consultant case. That is a consultant case. If anything has happened, we are not covered. So I had to now begin to behave like I'm in Nigeria. Make sure that I consult my consultant, even if I'm able to do the case. I became very famous in the hospital as a registrar who had been bold enough to do a consultant job successfully. So that's another aspect. You pat them on the back when they do good, and you scold them and correct them when they do the wrong things. Again, I said it could be on circumstance-based when you get a mentor. Like you're having some problems with your exams, for instance, and this is noted in the exam, and then there's a request from the floor that one of us should try and mentor this candidate. And that has happened a couple of times or a few times. And another circumstance is by intuition. When you see a candidate that is good, and like my boss spotted me as a fellowship candidate, you encourage the person, and you try to open up with information that can help the person for further education. And it can also be a situation in which there is a request. If you admire a consultant and you love the way she does things, decorum, you can request, "I'd like you to be my mentor." Of course, you have to be of good behavior, and you have to have impressed one way or the other the consultant. You cannot be a lazy resident and expect to be accepted very easily by a mentor. What else do I want to say? I think I won't take too much of the time. I think that's just some of my experiences that I want to share. That the way of choosing or acquiring a mentor are different ways. And also the responsibility of the mentor and the mentee has already been well discussed by Mary Rose. Thank you very much. I hope I haven't exceeded my 5 minutes.
Thank you very much, Ma, for those powerful words. And you said we can pat and at the same time scold so that it's balanced. So thank you very much. We really appreciate that. We still hear more from you. Over to you, Dr. Anaesthesia, please.
Thank you, Dr. Rotimi. And at this point, I want to offer the floor to our own Professor Shoyanwo. Prof. Ma, would like you to talk to us about navigating challenges in mentorship. Ma, you have the floor.
Thank you very much. Good evening, everybody. I first of all want to thank the organizers and also Rosemary for the brilliant lecture. She has virtually given most of the information, and we're just going to add a bit more. Before I go on to the challenges, I just want to remind us about what she said about who a mentor is and who a mentee is. Mentee is the one looking for something because he's actively seeking. He wants to receive guidance, support, and knowledge. And the mentor can be anyone who is willing to share his or her knowledge, experience, time, because there's a lot of time involved, and also possesses a strong desire to help somebody grow. So that kind of relationship means that there can be many mentors in somebody's life. And it doesn't necessarily have to be someone in the same profession. You can be mentored by anybody who is willing. I was mentored by, hello, can you hear me?
Yes, we can hear you, ma'am.
Oh, okay, yes. For example, I can acknowledge that I received a lot of mentoring from surgeons, from technicians, from nurses, especially during the period that a lot of our own teachers left the country. JAPA has not just started in Nigeria. So you may have people who are interested in you, and if you approach them or they think that there's a need to help, that can happen. But in that kind of relationship, because the roles can vary, like they can be advisors, they can be sponsors, like Rosemary said, they can be role model, they can be confidant. We had a lot of surgeons who were much older than us, and you run their lists regularly, and you virtually become members of the same family. Now, but those kind of relationships, challenges come because of the nature of our work. We are very busy, and we work in very busy settings. Professor Elegbe will also remember, when we first started, knife to skin, as we called it in those days, that is, surgery starts at 7 a.m. And nobody wants to know whether you have children to take to school, whether you have a home, whether your car broke up or you don't have a car. And one of the chief surgeons will stay at the door to see who comes late. And God help you if you come late. It's not an anesthetist, but it's going to tell you. And then you know that you do everything to make sure that you get to surgery early. Also, we do a lot of multitasking, especially the senior people who are the mentors. And they can be lecturers, they may have to cover more than one theater when younger people are also working with them. These are all things that can cause conflicts, and they can erode into the smooth running of the mentorship arrangement. Also, the structured programs that she talked about are often lacking. And you find that it's mostly the traditional mentoring that you learn from your master, as we say in Hippocratic Oath, that is available most of the time. But when you have structured program, that helps because you can set clear goals, and also the objectives will be known, and there can be matching programs between mentors and mentees. There can be a way of matching who is best for this particular candidate and who is not. Also, there can be training and regular meetings and evaluation so that the mentor can follow the progress. And benefits of such program include increased accountability, improved outcomes, and better support. And such mentoring circles, she mentioned the reverse mentoring. That is when you even have younger people mentoring older ones. I remember when we first got we were used to the simple boils machine when we started. And then we got some sophisticated machines. And all along my career, there are situations when is the resident that I will call, even when the days of monitoring came, because in those days, we used to have what we call human pulsometers. I know a lot of you wouldn't know anything about that, because that time you'll be anesthetizing for a major surgery, and you have to get a medical student to keep a pulse, to keep a hand on the pulse of the patient for you, because there was nothing like the pulse oximeter or electronic monitoring in those days. And God help you if the student should fall asleep or start feeling his or her own pulse. So, but when we have such situations, then the younger ones can even mentor the older ones. Peer mentoring is very common when you have your group discussions and other areas like that. And you can have a group of students that are mentored by the same individual. I remember there's still, you hear people saying, those are so boys, or so girls, or students, because that person must have been a great mentor. And the relationship is a long-term relationship, as she mentioned. It's not a one-time relationship. The third areas where challenges can occur can be when the mentor and mentee pairs, when they don't connect well. And we must remember the roles of the mentor, because it's not everybody that has the patience to mentor. Somebody who is going to mentor another person must be expected to be a good listener, and also to provide honest, constructive feedback to the mentee. Empower the mentee to lead their own career, so you don't have to dictate. But when you have somebody who wants to be dictating for the mentee, that can make the relationship break down. Also, if you have a mentee who does not understand the mentor, as Professor Legbe said, issue of you can castigate and you can also cajole. But I've listened to some mentees that will report their mentors. Oh, I stopped going to him or her because he said X, Y, Z. That is not the spirit of that kind of relationship. The mentee must learn to actively engage, must also be goal-oriented. It's not that the mentor will give an assignment. These days, a lot of things are online-based, and maybe the assignment, there's a deadline of 1 week, and then 1 week passes, you don't see the mentee, another week passes, and you have to keep on reminding the person. That is becomes very frustrating for the mentor, and this can cause conflicts in the relationship. The relationship is not just to mentor for the anesthesia per se. The mentoring will also include career prospects. I remember when we first qualified, Professor Legbe and myself, Professor Legbe went straight to anesthesia, and I started with pediatrics. And because of domestic issues for me, she used to tease me that, look, I have enough time to go to the market, to go shopping, to cook and all that. But you are stuck in the children emergency room. And in anesthesia, they used to give day off when you are on call for a whole day. And that was the enticement that I had to move from pediatrics and change to anesthesia. So that is also mentoring. She mentored me not on anesthesia, but on my general aspects of my life. And that helped me to make a career of anesthesia. And I remember after our own training abroad, we were able to mentor a lot of residents who we found positions for, not just in Ibadan. Those in Lagos were doing the same thing. Calabar were doing the same thing. Okay. That's not for me. Hello? Please mute. So anyway, and they found training positions abroad. And a lot of them came back while some stayed there, and we're still today very good, happy family. Now, the fourth point I want to mention is that expectations can be mismatched between mentor and mentee. A mentor may try to be convincing a mentee to do X, Y, Z, especially in terms of research and writing up their dissertations. And maybe the mentee is not used to what the mentor is saying, and the mentor gives a time deadline to do some assignments, and that is not happening. That can also give rise to a lot of difficulties. So these issues can weaken the potential of what mentorship is supposed to achieve. Hence, there, as Mary Rose told us, Rosemary, not Mary Rose, as she told us, there are a lot of information online that we can also use to help ourselves. But mentorship in anesthesia is not just about teaching skills, as we've heard, and should be with only the assigned, and it doesn't have to be with the only assigned supervisor in the department. It is about building character, resilience, professionalism, and leadership. And I hope I haven't exceeded my time. I can talk more during the next phase. Thank you very much.
Thank you very much, Ma, for your very insightful words. And Prof has told us that a mentee can have many mentors who do not even have to be in the same profession or in the same specialty. And she has told us about challenges with the family, multitasking, covering theater, lecturing, and lack of having a structured programs in our training. And she has also told us that most times we learn from the master where we don't have a structured program, and that a mentee, sometimes some of the problems can even be when there is a disconnect between the mentee and the mentor. Thank you so much, Ma, for your insights. Dr. Rotimi, over to you.
Thank you very much, Dr. Anaesthesi. Thank you, Prof. Ma. Another thing that I picked from what you said was that in those days, you were using human pulsometer. Thank God for advancement in technology. Because now, if you should try human pulsometer method with medical students, you'll be on your own. Thank you for that. And another thing too that I learned from what you said you could actually learn from technicians and even nurses. So one should be able to humble in ourselves to be able to learn. So one should not allow ego to come in. Thank you very, very much. We really appreciate that. The next speaker or panelist will be Professor Eguma. And I would like to ask, Ma, looking at your experience so far as a mentor, trainer, you held different positions. So what can you say about mentorship as regards career advancement? Professor Eguma.
Thank you very much, Dr. Rotimi. Like we have heard all evening, mentorship extends beyond learning and teaching of clinical skills. It is a lifelong supportive relationship. And I want to say that I have been particularly lucky to be mentored throughout my career by various people who have looked, helped me through not just the professional aspect of my life, but are there for me even on the personal level. An example of that is my mentor, Professor Sylvia G. Akpan. She's still alive today. She started me off. In fact, at the time that I took part 1 exam of the National Postgraduate Medical College exams, I did not know that there was a scholarship by the federal government for the best candidates for each year in each faculty. If it had not been for my mentor, who attended a faculty board meeting where this was being discussed, and this was like November, getting to the end of the year, and she said, "Well, have you informed her?" And they said, "Oh, we are going to write to her." You know that if this being November, by December, that scholarship is going to lapse. That year would have passed, and then they closed that chapter for the year. So she had to send a message to me and say, prepare to go abroad. Fortunately for me, I already, was making plans. I had placement. So it just came in good time, and I was able to go abroad, and that kind of widened my experience for the period I was there, and helped me in my further career. Now, mentors can act as career guides by helping the mentee to set realistic goals for their life's aspiration. They can also facilitate or sort of open doors or connect mentees to networking groups, resources, and opportunities. Again, I'm going to give an example with my life. A mentor of mine was given a job in post-war Liberia. He was asked to go there to develop anesthesia manpower for that war-torn country. But at that time, he was not ready, he told them, to leave what he was doing and go there. And so he asked them, can I nominate somebody whom I know is going to do that job for you? They said yes. And so he got in touch with me. And that was how I spent 2 years in post-war Liberia and trained nurse anesthetists, because there were no doctors to train in anesthesia at that time. They were just coming out of a war. And the first year, they graduated only 4 medical doctors. And these 4, they sent them to the county hospitals to go there as county medical officers. Like the county there is like a state here in this country. And so they didn't have enough manpower to take care of all the other diseases, preventable diseases, not to talk of to specialize in something like anesthesia. So I was left to deal with nurses. And, today, those nurses form the backbone of anesthesia in that country, up till today. So mentors, like I said, can open doors for you. They can give you opportunities that you otherwise would never have had. As a result of my tour in that country, I was privileged to dine with the president of that country, who was then a lady. I even was privileged to be present in their the Senate chambers for their State of Union address. I used to be included in the president's entourage when she's traveling around the country. So, I mean, it's apart from the anesthesia and clinical practice that I was doing, I was exposed to other things apart from that, and that was an eye-opener. So mentors can guide and teach their mentees to develop confidence in themselves. And this will enable them to navigate the challenges and complexities that they come across in life. Since mentoring is built on trust and empathy, it provides a safe place for the mentees to share their fears and challenges without being judged. And so this builds confidence in them and gives them what it takes, the resilience to manage stress and overcome whatever setbacks they come across. I will illustrate with experiences that I have had. I started my anesthesia journey as a senior house officer at the University of Port Harcourt Teaching Hospital. Then we were just 3 senior house officers in anesthesia, and then there were 4 consultants. There were no senior reg, there were no, intermediate, and we had no anesthetic technicians or nurses. So if you needed to anesthetize, if you had a list to do, with the SHOs, after like 3-4 months, were doing all the cases, you had no help from technicians or nurses. But we had a machine with a manually pole movement ventilator. So you will pre-oxygenate your patient with one hand, give the induction drugs with the other, and then intubate, and then hook the patient onto the ventilator. So your hands are free for you to pump the manual blood pressure machine. So there was this day I was on call, and I had done like 6 cesarean sections throughout the night. Then a 7th one came around 5 a.m. They just rushed her in and said, "Oh, severe eclampsia." And then they put her on the table, and she came with an IV infusion. So I just rushed it because I knew that by the time I finished intubation and settling the patient, that drip would have finished and I wouldn't have anybody to help me set up another one. So I rushed it down and then did my thing. And the surgery was done. At the end of surgery, I reversed the muscle paralysis and the patient would not wake up. So I was landed with delayed awakening. The surgeons went home, the nurses went home, everybody went home. By now it was morning, and I had to sit there with the patient on ventilator and wait until help comes. Help came. First, the head of department came, looked at me in the theater, and saw me through the glass. I sent a message to him, but he never came. Then another consultant walked in, peeped. It was a habit they had. They would peep through the glass to see what's going on inside the OP. And he saw me and then quickly changed and came in and told me to go home. He now put another SHO on the job to look after that patient. They had to cancel the list that person had to do, and then asked me to go home and sleep because I'd been up all night. I was so stressed. I was ready to quit anesthesia at that point. but I was worried about this patient. So I had to come back. I couldn't sleep. I came back to the hospital around 2 p.m. that day, and that was when the patient regained consciousness. It turned out that the obstetricians had put what they called lytic cocktail in that drip that they brought to theater, and they did not label it. So I didn't know there was something in it. And lytic cocktail, if you, I don't know how many of you know what it comprises. I think it's pethidine, diazepam, and another sedative. So all of these combined to keep her from waking up. But I continued anesthesia because that incident marked the beginning of the my very first mentorship in anesthesia. That consultant did not blame me for the patient not waking up. He did not blame me for anything I did. He took over and asked me to go home and rest. And after that, I went to him and I said, I want to leave. I want to do something else. He said, no way. You will do this. You are good at this. He is the one who bought me books in anesthesia. And most of my colleagues in anesthesia were reading those books. So I have been fortunate to have mentorship along the way as I went on with my career. So mentors can help in other ways than the actual anesthesia training. They can help mentees to find harmony between their professional and their personal lives. And this will create work-life balance for them. It is always a thing of pride when a mentor sees his or her mentee who has grown and become a well-rounded, resilient, and confident individual. As I sat here this evening at the beginning of this webinar, I listened to the speaker at this webinar, and my heart was full of pride because I saw somebody who came in to this training naive and green, who has now evolved into a confident individual and a specialist in her own right. I am referring to Dr. Rosemary Wokorie. So that was a good presentation that you did, Rosemary. Now, the mentorship is a two-way affair. The mentors also benefit from mentorship. Like I've said, it gives you that sense of purpose and fulfillment when you see someone you have mentored, doing well.
Great.
It also helps the mentor to develop or hone their leadership skills. Mentors also can be a safe place where mentees run to when they have setbacks in life. And so they can help them to overcome this. And that, again, is a way that mentors can be of help outside training, career training. So it goes beyond just the clinical anesthesia training. It's a lifelong supportive relationship and a life transforming relationship for the two both the mentor and the mentees. I want to stop here so that I don't eat into another person's time. Thank you.
Thank you very much. Really appreciate that. One thing that I noticed, or there's a take-home message for me. He said, if you need open doors, get a mentor. Thank you very much. We really appreciate that. Dr. Oran, it's over to you, please.
Thank you, Dr. Rotimi. I also noted that mentorship is built on trust and empathy, and I think this is very important for both the mentee and the mentor. Thank you so much, Prof. At this point, I'd like to welcome Professor B.O. Bolaji. Prof, you're welcome, sir.
Okay, thank you.
Yes,
Doctor.
and Prof, okay.
I hope you're hearing me.
Yes, we can hear you, sir. Sir,
All
we
right.
would like you to talk to us about mentorship in training and in trainee development, sir.
Trainee development.
Yes, sir.
Let's look at that word development. Simply, it means the act of improving by expanding, enlarging, and refining. That is what it means. Now, if a mentor is going to train a mentee to that level of development, you are referring to a relationship where the mentor will provide guidance, expertise to the mentee so as to accelerate their growth and success. And what are those areas? Let me first of all go to my own experiences. As a medical student, I had teachers like Professor Dunton, 81, 82, Professor Magbagbiola, they were all there, the older professors in our specialty. And I had a notebook, which was an old diary, and dedicated just to anesthesia. I still have that notebook because I still refer to that notebook. And I remember that during my student days, especially in the specialty in anesthesia, we were given assignments. And those assignments, you'll be told the exact textbook, the exact page, like synopsis of anesthesia. And going through those notebooks, that notebook, one day I just went through it and I saw something like, go and research on the layers through which a spinal needle will pass into the subarachnoid space. Those were the things we're researching on as a medical student. And I took that very seriously. I didn't know that I would end up in anesthesia because I had wanted to do pediatrics. But somewhere along the line, the passion for anesthesia came in. So I became a resident. First of all, I had to go to Calabar under the mentorship of Professor Sylvia Akpan. Thank God she's still alive. In fact, we communicate on a regular basis. And so when I got there for the postgraduate diploma in anesthesiology, I had two senior registrars there, or they were about becoming senior registrars, Professor Iguma, Professor Achimeshet. They were all there. And what I did as a diploma student then was that each time I went to the theater 8 a.m., I didn't leave that theater until around 8 p.m. because the hospital management gave us lunch. So I didn't see any need to run back to the campus where I was resident. So I would carry my books along, including that notebook that I had as a student. I still have it. I will ask questions. They were teaching me. Professor Iguma was teaching me. Professor Eshed, Professor Akpan. Anything they taught me in the theater, I just put it down. And then at the end of work, some people will be on call. I may not be on call, but I will stay and take the call with them. That was how I did my postgraduate diploma in anesthesiology. I never left the theater until maybe 8 p.m. and 9 p.m. But the day came that I was tested. After about 6 months or so, there was this patient that had APH and was bleeding torrentially. I was on call with a nurse anesthetist. The nurse anesthetist had an emergency. Her child was rushed to the emergency room, so she had to leave to take care of her child. And I was left with the technician. So what was I going to do? Would I send for Professor Iguma or Professor Eshed or Mama Akpan, who was the consultant? There was no way I would have waited for that. So what I did was to prepare the drugs. I just gave the drugs to, this was my second month. So I just gave the drugs to the technician that was beside me. I said, okay, give this, I'm gonna give it. So I just monitored everything. And I intubated the patient. The surgery went on, fine. The surgeon scooped the blood and did autologous transfusion. And we landed. The aircraft landed. So I think the following day or so, we had a meeting. And I was telling them what I did. Professor Akpan said, what? That was at my second month. Just to tell you how passionate I was for the specialty. I finished that, came back home to Ilorin because we didn't have any consultant, and all the ones that came left. They didn't stay. An Indian man came and left. An Egyptian came, left. One Dr. Amata, the older ones who know him, also came as a senior registrar, left. Another doctor came, left. Professor Dunton was here for sabbatical or so. And of course, there was no way he would stay. So I had to go to UCH on clinical attachment as a supernumerary. By the time I got there, of course, my mentors there, Professor Fameo, Professor Shoyonwu, Dr. Shotumbi, Professor Manobadu, Dr. Sanusi, and then, of course, Dr. Ogunwale, now Dr. Kende. They were all there. One thing I want to say here is that whether in Calabar, because I'm a 1983 graduate of University of Ibadan, so at least whether in Calabar or in UCH, I had people ahead of me that were my junior in terms of the MBBS, but I had to learn from them because I had that teachable spirit. I had to learn from them. Now, how did I do my residency? We had shortage of water a lot. Initially, I had an accommodation with a senior registrar who became a consultant and eventually left. So I didn't have a place. So what I did was to, let me use the word, commandeer the anesthesia call room in Penthouse at the UCH. I took over that room. I put all my things there. I bought a pocket, I put it there. So in the morning, I would just go downstairs. We had a bathroom in the theater. Just go downstairs. I'm sure Professor Shonwo is here now. She will not know what I went through. I'll just go down to the theater, take my bath as early as 5 a.m. I would have been ready. I'll go back. So if I was not in that room at the Penthouse, I would be in the residence lounge, particularly if I was on call, or I would be downstairs in the theater, in any of the theaters. And then I would either go to HOR, House Officers Residence, to eat, or the PSM to eat. And from Monday to Friday, I was within that hospital. I didn't go anywhere. And then, of course, the library was there. We also had Medline search. You just go and book, and then they will tell you when to come. They may give you 3 days, they may give you 1 week, and you'll be given just 1 hour. And of course, we didn't have the kind of luxury that the people have now, that they can go online and download whatever, but we didn't have that luxury. You had to go to Medline, do your Medline search for 1 hour, and then get everything you could get. And if journals came into the department, we made photocopies with the little money that we're making. So if I was not on weekend call, I could go back to Ilorin on Friday so that I could wash all my clothes, get things ready by Sunday or very early Monday morning. Latest by 8 a.m., I will be in UCH. And once I entered UCH, I went to that penthouse. I didn't move out of the hospital vicinity. I didn't go out to the city to look for whatever. I wasn't doing that. Occasionally, I could have gone out. But most 95% of my time, I was within that hospital. From 1992 to 1997, I was within that hospital. I didn't go anywhere. And I learned quite a lot. Now, as a trainer now, as a mentor now, what do I do? When residents come in, you know, now you don't even need primaries to come in. In those days, you needed to have the primaries. Once they come in, what I usually do is that I introduce them to the specialty of anesthesia. And I'll tell them the realistic expectations because the workload is very high, very high. Then the nature of our clinical work. I remember there was a resident that came in and I had told him that, look, can you cope? He said, yes. So he started, I think after 6 months or 7 months, one day he just collapsed and he landed in the ICU. He was comatose. I can't even remember what happened to him for a period for like 3 or 4 days. Then eventually he came around. We had to approach the management to get him out of anesthesia department. So eventually he ended up in radiology because he knew that there was no way he could cope with the workload. You know, we're not many in the specialty. It's just now that we're having people coming in. When I took my part 1, we were only 6 candidates. But now you have 70, 80 candidates coming for the NPMCN part 1. But in those days, we were very few. So I also tell them the academic aspect of residency training, what is expected of them. And then, of course, the curriculum. And I always tell them, make sure you are in contact with the college website so that you know what is expected of you, you know the scope of the curriculum. And then, of course, I also tell them about the examinations. Now, one area in which they can develop is in building skills. That would be the clinical skills, academic. Can you all hear me? Hello?
We can hear you, sir.
Okay, because can you please mute that person? So building skills will include clinical skills, academic skills, research skills, and even relationship skills. Relationship with colleagues and patients. You know, there is this form that residents fill in annual performance and evaluation report. Usually you must have 2 prepared before you take any exam in the NPMCN training or program. And one of those things that you need to score, one of those criteria points that you need to score patients on, candidates on, is on relationship with colleagues and relationship with patients. You need to score them on that. Those of you who've been training and scoring candidates, you know what I'm talking about. So clinical skills, various techniques of anesthesia, and depending on what the patient is presenting with. And I always encourage them as much as possible to do as much as they can do so that they can sharpen their skills, so that they can acquire these clinical skills. And of course, I encourage them to look at their logbooks, because when you look at the logbooks, whether for the junior residency training, senior residency training, the skills that are supposed to be acquired are always there. But we have to ensure that residents actually acquire these skills as prescribed in the various logbooks. After academic skills, okay, what about the research skills? Well, I encourage journal reviews as much as possible, even for junior residents. although usually it's the senior residents that present, but the junior residents also participate. And then, of course, when there's research in the department, I also encourage my residents to participate. That helps in building them, in developing them. And of course, they need to be confident. They need to be confident. How? You encourage them to participate in all activities. But as they participate in all activities of the department, whether clinical activities, academic activities, research, presentations, they become more confident. And I'm very close. As much as possible, I want to be close. One of them was telling me recently that, oh, Oga, I didn't know that you could be like this. I thought you were a tough person. But that if he had known earlier, he would have been relating with me when he came in. He didn't know the kind of person that I was until I started relating with him. And one thing I also encourage them to do is to read reference texts. I discover over the years, marking scripts and listening to events, that their knowledge base is becoming very shallow, very shallow. All the they do not have scientific basis of what they are doing, of some of the procedures. They don't have the scientific knowledge. So when you take them down to when you now take them on basic principles of the procedures, of the techniques, you find that they are shallow. So I encourage them as much as possible to get reference texts and read them. In our own days, we bought textbooks. I still buy textbooks. Recently, I bought Miller's textbook, volumes 1 and 2. I have it in my library. I have a problem-oriented Yawa Natusio, recent one. I have it. I just downloaded the recent version, the recent textbook of anesthesiology by Morgan. I just downloaded it because I needed to read something there. So encourage them to read texts so that they can have the knowledge base, and they should not abandon the basic sciences because they need it. They need them. They need the basic sciences, right? Professor Shanwo has talked about setting goals. This is very, very important. Every resident must set goals. And you should, set goals on the various topics, the various specialties, and then set goals on when to study them and when to complete. For instance, you take pediatric anesthesia. You have pediatric anesthesia, obstetric anesthesia, regional anesthesia, geriatric anesthesia, then all those endocrine abnormalities. You take all of that, and then you list them out, and you begin to read them. Set goals that between so and so time, I would have finished this. And then as you read, like I used to do, also make notes. I made notes, and I still have notes. And in the days where our update resource persons were using transparencies over projectors, there was no way anybody would give you his or her transparency. Any resource person would do that. So we sat down, listened to them, took notes. So all those all the resource persons in our days, 1992, 1994, late Baba Oladapo, Professor Shoyanwo, all the things they taught us during the update, refresher courses. I still have them written. I still have them, and I still go through them, and I look at those topics. They are still relevant, even if there are new things, but those were the basis on which we developed, on which I developed. So I make notes. Sometimes I didn't have money to make photocopies. So what I did was I sat down and I wrote the whole topic from Canadian Journal of Anesthesia, from British Journal of Anesthesia. I did that. I still have them and I still look at them. So that was how I studied. I had to do that so that I could grow. So set goals and desire to achieve the goals. And I believe that every mentee should carry his mentor along. I say it here, particularly in the area of proposal writing. When residents complete once they pass the part 1, they just think that that is the end of the training. So I always encourage my residents. First of all, get a topic. Get a topic that is researchable. Get a topic that you'll be able to, get a topic, okay, what are the research questions? What will be the aim? What will be the objectives? Let's see if we can get, how many objectives can we get there? And then we'll start. My new method now is that, okay, give me from introduction, which will include the background, the research question, what has been done, or what is the magnitude of the problem, what has been done in the past, what gap of knowledge you want to fill, then give us the broad aim and then justification. You do that, give me the aim and objectives and then a hypothesis. And we stop there. I don't want to see everything. So we just go step by step. When we finish that, I look at it, we're okay, all right, okay. Now, go ahead and develop the study protocol. Let's look at the methodology. So they do the methodology separately. And then we'll come back, we'll look at it. So that's the way I take my residents. I don't want them to just do everything, literature. No. Let's take it. And that's how it's done in the PhD. You don't do everything at once. And that is what I do for my residents. So a lot of residents, when I go for accreditation, I see that people price part 1.5 years, 2 years. And I ask, where's your proposal? And they tell me that, they are still working on it.
Wow.
2 years after the part 1. Yes, I've seen that. 2 years after the part 1, some residents are still working on their proposal. Whereas by 6 months, they should have something on the supervisor's table. Let me just say 1 or 2 things about supervisors now. I have discovered. Oh, no, please. I'm not finished. I have this. You are going to give me like 3-4 minutes. I have discovered now, although I know I have 5 minutes, that a lot of supervisors do not supervise their residents. They leave the work of the proposal to the assessor. And that is not acceptable. You see it quite a lot, and some assessors have been complaining. And if you're going to be a mentor, I believe you have your own responsibilities and look on hello?
Yes, we can hear you. Apologies about that, sir. The person has been muted.
Okay. All right. So continue. I think then, of course, I encourage my residents to participate in conferences, NSA, SAM, so on. I encourage them to participate and even present topics, because that will build confidence in them. That will also help them to develop. Thank you very much.
Thank you very much, sir. We really appreciate this wealth of wisdom that you've communicated. Thank you so very much. We'll move speedily to Professor Desalu now. And Professor Desalu is a prolific academic, and she has published over 100 articles. And she's also passionate about training and has supervised over 25 or more than 25 fellowship dissertations. So, Ma, what can you say about mentorship as regards dissertation and also research. Thank you, ma.
Thank you, Dr. Rotimi. Can you hear me? Because I'm using my phone, but using my laptop at the same time. Okay, great, fine. Good evening to everybody and all my teachers and senior anesthetists, as Dr. Kalu said. When she said there was senior anesthetists, I was thinking, what am I doing there? She said, and some that are not so senior. So I now realize my position. So thank you very much. So I'm going to talk about mentorship in research. Mentorship in research goes beyond simply supervising a project or guiding a literature review. It means developing an environment where the mentee is encouraged to think about questions, develop those questions into research, critical thinking, and is not afraid of failures, because failures will only make you learn. It encourages curiosity, resilience, good ethical research practices, because that is so important. Even if you're doing a questionnaire study, you require ethical approval, and people need to know that. It also helps the mentee to navigate the challenges of securing funding, balancing clinical commitment, and that's always a problem. Where is that paper? I've been on call, so and so has been on leave, and I haven't been able to do it. So they have to balance everything together and also build their own collaborative networks. Not my own. Don't join mine. I have built mine. You build yours. But first of all, I need to pay homage to my mentor and explain how I got into anesthesia, because I was never going to do anesthesia. I was going to do hematology. But like every good student during the surgical posting, I was doing orthopedics, and they had opened the bone and they were cracking bone left, right, and center here. So I just wandered off. As I wandered off from theater 6 down the corridor of modular theater, I just peeped into this theater and I saw this crying child. Child was crying, and this diminutive lady, I think maybe in those days, maybe they didn't have milk, because many of them of that age group are quite petite, and you can put in the pockets. So this diminutive lady, she just did something, put one thing, put one mask, and did something, and the child stopped crying. She did something else, then she crossed her legs. She had precordial stethoscope in her ear. She crossed her legs. So professional and wonderfully wonderful. And I said to myself, oh, I want to do that. I want to be able to do that magic that lady did. And so I jumped into anesthesia with her. Not only did I jump into anesthesia with her, I jumped into pediatric anesthesia with her. And I am proud to say that I jumped in after her, and I have a couple of people that have jumped in after me. So there's something that she taught me that I taught others, that they feel that they want to come into pediatric anesthesia. When I started in research, the first thing I did in research, besides doing my dissertation, so I did a dissertation, which was new in those days, and I did dissertation for both colleges, because then people were still writing book of 12 cases. So I was an expert, in this dissertation business. So I thought. And so my mentor asked me, she said, I don't know how to do this. Say, come and draw tables and charts. And I drew tables and charts. And I was number 5 on the author line. When the article came out, I bought 15 copies of African Journal of Anesthesia and Intensive Care. I gave one to my father. I gave to my husband. I posted to my sister in America. I posted another. I said, see my name on the author line of this article. And that was where it started. But I didn't get into research just like that. It wasn't easy. And when residents come up to me, or even fellow consultants, mentees, and they're having problems, and they say, you're good at it. No, I was never good at it. I bring out my part 2 dissertation, my proposal, that was assessed by Professor Akpan. And when I show it to them with all the red marks up and down, And the way she wrote it in the proposal, how to write a literature review, I said, this has not changed. How to write a literature review has not changed from the day I wrote literature review in 19, whatever it was, and it was corrected by my assessor. It hasn't changed. Follow these basic principles. But it doesn't matter what you tell the mentee has to be enthusiastic for growth. They have to want to grow. A mentee cannot come to you with the same problem over and over and over again, and you don't see any improvement. It gets a bit frustrating and it gets a bit disappointing. You know, we've sat down, we've talked about how to write objectives. The first paper, you didn't write it right. I sat down and I taught you again and again and again. And we are still on paper 4, and you still do not know how to write objectives. Then there's a problem here. Either I am not putting it across to you, or you are not receptive of it, or your own pace is different from the pace of mentee 1 and mentee 2 and mentee 3. So as mentors, we need to understand that mentees go at different paces. Now with my mentees, the people that I've mentored, of course they start off by maybe supporting the research study, but I always make sure that they're part of the research team. Right from the beginning, they're part of the research team. You're not just data collectors. You need to understand the whole research, why we're collecting this data and how important the data is. And we have periodic meetings, updates. So what have you gotten here? Oh, I've looked at the data you've put in. It's not correct. It cannot be correct because the point is on the wrong point, or this child cannot be 1.8 meters and you say he's only 6 years old. What is the problem? There's a problem here. So we always work as a group. So with my mentees, I said they start off by supporting the research study. Then I encourage them to identify areas that they may have problems with. Is it drafting the objectives? Is it analyzing the data? Is it ethical issues? Is it writing informed consent? And I sit with them to show them how. I will sit with you one-on-one to show you how. And I encourage my mentees to come back if they're having problems. Come back with as many revisions as you choose. If I have decided to take on this project with you, this research project with you, then we're going to see it all the way down to the end. Set realistic deadlines. Don't tell me that, oh, I'm going to get the literature review done, I'll give it to you by the weekend. It's not going to happen because I can see that on the roster you have 2 calls. And I know you are going to do locum outside. So please give me realistic deadlines. Somebody's smiling. Give me realistic deadlines. Give me the day you are going to come to do it. And I will wait for you. I will wait for you. I will have time and I'll wait for you. Mentoring takes a lot of time. A lot of time. And one of the things I always say to especially postgraduate students writing their dissertation, if I'm supervising you, I insist you do your own statistics and data presentation, because that may be the only time you get someone to sit down with you and teach you statistics and how to present your data. And the first thing they say is, I don't know how to do it. I said, don't worry, I will show you how. But if you are doing something that I don't know, then I will direct you to the person that will show all of us how to do it. And then from then on, we'll move on. Or direct you to the previous senior registrar who has done it and let them help you to do it. So we have to show them how to do it. Statistics is it's totally different. People get upset with it, they get afraid of it, and you forget it if you don't apply it. That's why I like my senior registrars to do their own statistics. If they do their own statistics, they will find it easier when they're writing research to do the statistics with the research and know how to draft their questions and know what data they want. But you can only teach what you know. So you have to keep on and on and on at it. And there's no better joy than seeing a mentee of yours who can even do it better than you. When anybody comes to me with objectives and they say they're going to do correlation, association, I say, I don't know how to do correlation. I don't understand correlation. Please go to X She's very good in correlation. And that person will even teach me correlation. So we're talking about reverse mentoring. I have been mentored in statistics and research by a surgeon, by cardiologists. They have taught me more and more and more. And I also encourage my colleagues, my junior colleagues, that if you have a question about a clinical practice, then let's also research it. It's not just a question. Every time we go into theater, we should be collecting data, as well as the fact that we are doing clinical service. We should be collecting data for something or another. A surgeon once told me, says, if you know you want to become a professor, the only way to do it is that at any point in time, you must have a manuscript that's being reviewed, one that you are writing, one that your mentee is collecting data, and one that you're thinking of. And it just moves along like a train. Each aspect will move along to the next aspect, move along to the next aspect. He said, if you do that, you'll have 4 or 5 papers in a year, and you will become professor at the minimum time. And it worked. And so that's what I tell people that I work with as well. Do that. Do that all the time. And then once you brought your mentees up, you have to let go of the apron strings. They can't hang on to you all the time. Allow them to build their own teams and become mentors. And I tell my mentees that, no, don't put my name at the end of that paper. You can acknowledge me, but you need to be able to prove to the scientific population, the research population, that you can write without Desalu. And you have written it without me. Because I read it doesn't mean you just pop my name at the end. Acknowledge me in acknowledgement, and let it be you and your own team of mentees. I will finish up by just cracking a joke here. There's no better joy than seeing your mentees just do well. You just sit back and you are so pleased. I remember when I was going to have my inaugural lecture, and I wanted to ask, I spoke to Professor Kushima. I wanted to ask her something. I said, I'm going to change something. Can you help me look at this thing? She said, no, I'm very busy. I hope she's not on this platform now. I'm very, very busy. I said, but the lecture is tomorrow. She said, yes, I know. I'm going to do my hair. I said, you're going to do your hair? I'm the inaugural lecturer. She said, yes, but I'm the mother of the inaugural lecturer, and I'm going to have my hair done. So for those of us in the academic position, we need to move on. We need to write papers. If you've written a paper 10 years ago, you can ask your mentee, why don't you look at whether there's been a change? What has happened between there and now? Have we had more equipment? Are we now doing the surgical safety checklist? Why don't you look at it? Take this one, see what we did, improve on it, and let's work together. But it's all team effort. And when we're writing papers together, if I send you, I will always send the paper to every single member of the team, and every single member of the team has to comment. Don't be afraid of saying, this doesn't sound right, or I'm not sure this is it because Desalu wrote it. That is internal peer review. That will teach you how to critically look at things. And whenever we make edits, whenever we make corrections, I circulate it to all the members so you can see what you missed, see what somebody else picked, and begin to learn the nuances of research. So please let us go after our questions that we have in clinical practice. Let us turn those questions into research questions, and let us produce more research from this part of the world. Thank you very much for your attention.
Thank you very, very much, Ma, for those powerful words, and also the words of encouragement for those that are coming up in that space of research. Thank you, Ma. We are pressed for time, and our time is fast spent, so we'll not be able to have the second round. However, I'll just go straight to the Q&A session now, and thereafter we'll round off. So I could see one question here from Dr. Bisola Onaji-Obimbe. She says, how do you recognize mentee burnout, and how do you help your mentee deal with it? Then the second aspect of the question says, women anesthesiologists have diverse challenges, including family and children. What strategies have you used to ensure female mentees stay in anesthesia and complete their training? I wouldn't know which of the panelists would like to respond to the first one, and who wants to respond to the second one. The first one, how do you recognize mentee burnout, and how do you help your mentee to deal with it? Anyone, Maz? Sir? Would any of the panelists like to respond to that?
Well, can I try? It's a long time since I gave anesthesia, but I remember how stressful. I still remember how stressful it is as a female anesthetist. I remember when I was going to show you how stressful I found it, I retired at 65 years instead of 70, because I retired when professors were being told that they could stay till they're 70. And I said that when I was leaving, people asked me, what are you going to be doing? I said, I know what I will not be doing. And what I will not be doing is clinical anesthesia. And today I don't regret it. So I agree with just to tell you that it's a very important question. So because I mentioned when I was talking about multitasking, and who multitasks more? Is it the man or the woman? Unfortunately, we go into anesthesia thinking that, oh, it's going to be soft landing. And then when I was leaving pediatrics, there were 3 of us who were residents in pediatrics, and that was when they were starting the postgraduate training. By the way, I started the postgraduate training, which was started in Ibadan, which was called the MED. It was a university program. And then they moved it to the National Postgraduate Program. And in those days, we go to basic sciences for lectures in the morning, and then you come back to run your afternoon clinic, and then you will go to children emergency room for night call. And you are still going back to UR in the morning. So I guess it's still very tough on women. So in terms of identifying stress, definitely there will be some signs of stress that one will notice, especially if the person has a mentor or mentors in the department. And signs of stress, even without examination, somebody that was soft-spoken before can become easily irritable, maybe, then other colleagues may complain, personality changes may start creeping in, and then the person might start having medical symptoms and showing signs of not being able to cope. Maybe accidents when she's given anesthesia and all that. So I would say that in terms of managing, if this is noticed, definitely that person will need a lot of support from not just the seniors, but also from colleagues. I remember when I was in practice, there were some residents that we had to give days off or rearrange their call duties so that they can have long weekends, especially if they have children and the husband is not around, so that to make the home environment for them more favorable and their working hours easier. So, and then if the supportive strategies are not enough, you may have to now advise them to go to see a doctor and go for medical checkup and sort out whatever needs to be sorted out. And they can even request for compassionate leave, and this can be defended within the department. They can have casual leave, so to make them, or there are some that will tell you that I find this particular list more stressful, or this particular surgeon, I don't want to work with that particular surgeon. So you may have to step in and diplomatically do some things about it without ridiculing the person. And the important thing is that the person must go to the staff clinic. The other day in the unit where I'm conversant with now, I went in and I found this doctor lying down on a mattress because she was ill. And I was so aghast. And I said, "What are you doing here?" He said, "Because the patient can come in and I'm the only doctor on duty." I almost told her that you want to kill yourself. So I forced her to go to the staff clinic. And then one of the matrons came in and said that happened a few years ago with a nurse on one of the wards. And the supervising matron came in and found the person on the floor and forced her to go to the clinic. But for one thing or the other, she told me that within 24 hours that lady died. So which means whatever was wrong was something very critical. So we must not take it for granted. People can have burnout, and they can really fall in. And if possible, it's better to prevent burnout. But from my experience in anesthesia, it is almost impossible to prevent the stress level getting to that level if you are hardworking, if you are dedicated. And in my talk, I said, oh, okay, the second part that we were supposed to talk about personal growth. Yeah, because we are all concerned about personal growth, we tend to push ourselves too much without trying to apply the brake when necessary. So everybody should know their own limits and also know the coping skills, and especially their mental status and how to cope to lead a fairly comfortable life and look at their life in a holistic way rather than just work. So that's my take. Thank you.
Thank you very much, Ma, for those words. We really appreciate you, Ma. We will all agree with me that
sorry, can I say something, Dr. Rotimi?
Oh, okay, please go ahead.
Just a minute, yeah. I find that consultants, academics, they multitask and they do so many things at the same time, and they get overwhelmed. They're doing clinical work, they have to do their research work, they have to do admin, they have to take care of their family, they have to take care of themselves, and they get overwhelmed. And so it's very difficult getting that work-life balance. But not only for females, even for males, because yes, the females are taking care of the family, but the males are out there. When they're not working in the hospital, they're doing locum because they're looking for more money to bring home. So it cuts across both genders. And so what I always try to tell my mentees is that, first of all, don't get overwhelmed. What I do is I have a book, a calendar book, and I write everything in it. So if I have to deliver a lecture on the 1st of November, I will put it in on the first week of October, so I can start writing the outline. Second week, October, I will put it in again. Don't forget the lecture. Third week, so it's not that 3 days before the lecture, you are trying to get this lecture done. You have clinical commitment, you have research commitment. So give yourself realistic deadlines with enough time. Start the work early. Whatever it is you're doing, start the work early so that you're not pushed at the end. It's when you're pushed at the end with so many stressors that you just get overwhelmed and you just get burnt out. Always remember to take a day off if you can. 1 day out of 7 days, don't do anything related to anesthesia, don't do anything related to admin. It is possible. Even if it means you work on Saturday to 2 a.m. in the morning, knowing that after you've gone to service on Sunday, you're coming back, you're not doing anything. Nothing is going to make you open that laptop till Monday. Everything else can wait till Monday. You need to be able to give yourself, your brain, and your body time to switch off and regenerate, because you're not helping yourself if you just go at it all the time. Thank you.
Thank you. Thank you very much, Ma. We really appreciate those comments. And we'll all agree that we've had an insightful and an impactful meeting. And on behalf of the organizers, I want to sincerely thank all our panelists. Professor Elegbe, thank you, Ma. Professor Sonyowo, thank you, Ma. Professor Eguma, thank you, Ma. Professor Balaji, thank you, sir. And Professor Desalu, thank you very much, Ma. And also our lecturer, Dr. Nwokore, thank you very, very much, Ma, for that powerful lecture. We really appreciate it. So we are sorry we're not able to continue. So if you have any further questions, you can please communicate directly to any of the panelists. They are available and accessible. Thank you. Over to you, Mr. President, sir.
Good evening, my teachers, mentors, and colleagues. It's been a very difficult week for all of us. This has been on, but then we had this, we are saddened by the demise of very senior colleagues who will have also loved to say something on this forum. So I don't want to say much, that I have benefited from all these people that have talked. They see my call, a missed call, they call me back. And I realize that it's mentoring for life. And there's also reverse. I'm beginning to also enjoy the reverse mentoring or mentorship. So we will find a way of making this maybe happen, maybe at least once a year in a very different way. So we take an aspect so that we enjoy more from this. You agree with me, with just scratch the surface. So I will leave it at that because we had a great 2 hours. This is just the beginning. We will plan something and we will consult again our mentors for guidance. So if you permit me, I want to, we will dedicate this great discussion that we have to our late Baba Oladapo and Dr. Shotunbi. Thank you very much. Thank you.
Thank you, everybody. And that brings us to the end of our webinar for today. On behalf of the Education Committee of the Nigerian Society of Anaesthetists, a very big thank you to all of you for joining. Please go back. The videos will be on our YouTube channel, and you can keep enjoying this very engaging and interesting session. Thank you all.